Good evening, all of you. Warm greetings from Nurses Initiative for Community Empowerment, NICE. I am Denny Maria Muman. The NICE Notes on Head will be the moderator for this webinar. I am overwhelmed to see enthusiastic nurses in NICE and especially your dedication for getting empowered to empower the community. As we all are aware, annually March 24th is observed worldwide as World Tuberculosis Day, which is pivotal moment for raising awareness about tuberculosis, a global health concern that affects millions of people worldwide. This day serves as a reminder of ongoing efforts to combat TB and the need for continued action to eradicate this infectious disease. Although elimination of TB is our sustainable development targets, which is to be achieved by 2030 by the world, India has set the target of 2025. But according to the World Health Organization, only 60% of the TB cases in India are notified to National TB Program. Incidentally, most of the patients do not seek medical attention at all or are diagnosed with TB only in its late or the advanced stages. As we all know, that there are various challenges on the road before we see the sunrise of TB elimination. First of all, the lack of access to the healthcare, especially to the rural and remote villages. Secondly, the highly increased number of the drug-resistant TB cases in India, which make the condition really worse and the condition difficult to treat and may require more expensive specialized drugs and longer duration of treatment. Let's hope and join with our state health systems in the effective and efficient execution of TB elimination. But meanwhile, we have to cater the needs of patients who are already diagnosed with tuberculosis, that is, the people who are living with TB. A pragmatic, client-centered approach is essential to manage those clients of TB. So, in today's NICE webinar on World TB Day, the topic is Living with TB, a client-centered approach in order to pave a path to put an end to this infectious and debilitating disease. So, you may be required to remain muted and make use of the chat box for your queries and the questions which may be dealt at the end of the webinar. Speaker for today's webinar will be Ms. Divya Sojan, a postgraduate nurse from AIIMS College of Nursing, Delhi, and presently serving as nursing officer at AIIMS, Delhi. She has been acknowledged as an expert at the first international conference on health and well-being on TB elimination by the Government of Kerala as a panelist for the discussion on making TB-free Ireland a way forward. She was also a keynote speaker at India TB Summit of 2021 as well as 2022. She was also an expert at 51st Union World Conference on lung health. Moreover, when I say that Ms. Divya is most appropriate resource person because she has conquered TB thrice. So she is a true fighter and a courageous TB survivor. So let me take this opportunity to welcome Ms. Divya Sojan to talk to you on the realms of the topic of the webinar, Living with TB, a client-centered approach. Over to you, Divya.
Thank you, Denny, for the warm introduction. Good evening, one and all. I would like to extend my heartfelt gratitude for giving me this opportunity on a World TB Day to share my thoughts, my story about living with TB and a client-centered approach. So, Denny have already said a path. Why is it important to talk about TB at least once in a year? So, the objective, Denny. So, this evening I would like to put up or show a little light on the overview of what's happening worldwide with TB and what is the difference between TB disease and an infection. What is TB preventive treatment and why it is important? As we all are health professionals, we are meeting TB patients. Different patients may be infected, may be active, having TB, active TB. So it is important for us to know what is TB treatment as an advocate as well as for taking care of ourselves. And a little, but at the last, living with TB. How was a patient, what it feels like. So next slide. To introduce As we all know, TB is a communicable infectious disease affecting around 1/4 of the world population. That means if we have a population of 100, about 25% of that population is affected by TB. That is a huge number. Tuberculosis has existed since antiquity. In 1700 BC, the mummies which was taken out, they had TB infection in their bones. So from ages, TB is been existing in the community, and it is also colloquially known as white death. Why it is known as white death? Because when a person is infected with TB, those days the person will have the infection. It will take over the immunity. The person will have loss of appetite, weight loss, and the person will become paler and paler, like whitish. So it was, and finally the person will die. So it was known as white death. The BRICS countries account for 47% of the total number of TB cases annually. The BRIC countries include Brazil, Russia, India, China, and South Africa. These 5 countries globally records about 47% of the total cases across the globe, out of which India aids about 28%. That means India is a hub of tuberculosis. Every year 10 million people fall ill because of tuberculosis. That is a huge number. Despite being a preventable and curable disease, 1.5 million people die from TB each year. Whenever we say about tuberculosis, we always say it's a treatable and preventable disease, curable disease. Then why so much people are dying across the globe? It is much more infectious than COVID, but still nothing we are able to tackle to get the number down. So when we say about the history of TB, the first Dr. Koch in 1880, March 24, discovered the bacteria tuberculosis, Mycobacterium tuberculosis. So we remember or we celebrate the World TB Day on remembering his discovery. The BCG vaccine was first used in humans in 1921 in France, about 40 years later. But the first TB Day was celebrated in 1982, about 100 years after the invention or the discovery of the bacteria, which means in 100 years, there was not much of work or innovations that came up, and the disease was increasing in number across the globe. Why is it, Denny also said about why is it important to talk about or celebrate, or we need to look after this day, World TB Day, because this is such a disease, in fact, highly infectious disease, high in number. So we need to educate and provide an awareness to the community so that we are able to tackle the disease. WHO is aiming or goaling at eliminating the disease by 2030, where in India we target an elimination or eradication by 2035. So being said, why we know this disease is in the community or across the globe for centuries. We don't even know when it was first discovered, first patient came up with, but still, why at this point, being coming after 3 or 4 centuries, why it is of importance at this moment? Because this disease, tuberculosis, was said to be a poor man's disease. Like when I had first TB, my mother's expression was it happens only with people who don't have to eat. How you can have this disease? Because it was always linked with malnutrition. But in India now, when we look into the statistics, it's not a poor man's disease. The disease is widespread. It could be lower economic, it could be middle economic, it could be higher economic. Any income strata, the disease is seen. Why it is seen? Because the risk factors. Being a health professional, we are a risk factor. We are a very vulnerable group. Then the risk increases with immunocompromised state. People with HIV, living with HIV is increasing. People on anti-tuber treatments are increasing. People using alcohol, tobacco, smoking. Then people with diabetes and kidney diseases. Non-communicable diseases across the globe is increasing. So it's not a poor man's disease anymore. The disease is widespread. When we look into the statistics of coming to India, India caters about a quarter of patients. About annually, when it is 10 million globally, we have 2.5 million cases. That also includes persons who are having relapse of tuberculosis, and 400,000 deaths every year. That is much more than COVID deaths that occurred in 2 years. 400,000 people we are losing every year in India because of TB. And we have the highest hub of MDR TB as well. So why MDR TB comes into picture? Why we are not able to tackle the patients at a much prior level? Because when we look into the Indian scenario, we can see that when a person is having fever or cough, the person being a health professional, what first step we do is we just treat it with common antibiotics like azithromycin or something else we take. And if it's not subsiding, we will shift to another higher antibiotic. If still it's not subsiding, we will seek some medical help. And maybe with some cough suppressants or antibiotics, it will settle. But TB diagnosis is not that usually taken into picture. So in 2024, the WHO came up with the theme, yes, we can end TB. When we say, yes, we can end TB, this theme, yes, we can end TB, conveys some messages. The first message is call for action. Yes, there is a cry for help or a cry to mobilize global efforts to end TB. There is a global initiative which is happening across the globe, which is being talked or spoken across the globe today to mobilize efforts to end TB. It emphasizes on collective responsibility of individuals, community, government, and organization in combating TB. That's a call for action. Everybody has to do something to combat TB. Then there is optimism. With the word yes, there is hope. It affirms hope that we will be able to eliminate TB. Plus, it acknowledges the progresses till date we have come across. Then it also inspires that optimism that we need to do something to eliminate TB with further actions. Then there is empowerment, empowering the community, the individuals to advocate in preventive and treatment options, initiatives. Like the term we can do something. So that everyone has a role to play. Not only the health professionals, the community as well has a role to play in ending TB. Awareness, as we are doing now, this day we talk a lot about TB so that there is adequate amount of awareness and education among the community, among the healthcare professionals, so that we don't lag behind and we take the best treatment or the new advancement in the treatment modality. Then there is innovation in the team. Yes, we can end TB means there should be innovation. As we already said, the vaccine was first, the BCG vaccine was started in 1921 and we are in 2024, about 100 years. Still, we are having only that one vaccine to prevent TB. That means no newer vaccines has come up, even though we have few medications that have come for the treatment part of it, but in the preventive part, we have only one vaccine, the BCG vaccine. And that also the studies have shown that it reduces its efficacy by 10 years. So why is it important? It is important because when the child is given at birth, the BCG vaccine, at least 10 years of life, the severe disease of tuberculosis can be prevented, thereby decreasing the load in the children. The children load of tuberculosis is reduced. So 10 years, the child will be probably having the decreased TB load. So that is innovations. We need better drugs, we need better vaccinations, and better adhering treatment protocol to be taken care of. So these are some of the messages that WHO tries to convey with the theme, yes, we can end TB. Next, tuberculosis. When we say about tuberculosis, we are all nurses. We are learning tuberculosis from day first year of our nursing education, I believe. Like communicable diseases, then come to med-surg, a very big topic, then come to community. We teach the community. The tuberculosis as an infectious disease have been a part and parcel of our nursing education as well as our job. So what is TB? Just an overview, just to refresh our memory. It's a common communicable infectious disease. A person having a TB bacteria, when coughs or sneezes, the droplets come out, the aerosol, which is inhaled by another person. So then another person inhales the droplets or aerosol, and then the person have the mycobacterium tuberculosis inside him. If the immunity is well enough, the person will not have an active disease. The person is still told to be TB infected. So when the TB bacterium gets into the system, through the aerosol, obviously it's going to into the pulmonary, into the lungs. So when if the immunity is less, the person will develop a pulmonary tuberculosis. So if the immunity is well, the host immunity will fight with the tuberculosis bacteria and it will go into a latent stage. The active signs and symptoms will not come up. So since we are all health professionals and India comes under a low middle income country, malnutrition is there in the community. So the mostly people who doesn't have who come from a low income group, or somebody who is having immunocompromised state, they are at a high risk of developing the active signs and symptoms. So when this bacteria multiplies in the lungs, it will travel through the blood to other sides of the body. Like when it travels to the CNS, it is known as TB meningitis. It can go to the genitourinary system. It can go to the kidneys. It can go to the stomach, intestines, wherever it can multiply even to the bone. So when it goes to some other part and it multiplies, it is known as extrapulmonary TB. And to tackle or treat the extrapulmonary TB, it becomes another big complex issue. Then that is the second. First is the pulmonary TB, second is the extrapulmonary TB, and third we have the miliary TB or the disseminated TB. That means the person has TB infection not only at one site but different areas. Well, usually in miliary TB, what happens? The different drugs has to be given over a period of 18 to 24 months. That means more than 2 years, more than 2 years, the person has to be on treatment, which is I am very sure having antibiotic therapy for 7 days, how ill we feel. When we start to feel better, we often tend to stop the antibiotic even after 3 or 4 days. So think of a person who has to take that treatment for 2 years. When obviously if it's a person feeling better, there are high chances they will stop the medicine. There is a high chance, people who are on daily wages, they are not able to afford medicines for such a long period. They will stop the medicine. So these are all problems that the country or globally we need to tackle so that we are able to stop the spread of tuberculosis infection. So I'm very sure you all know about. Next slide, please. Yeah, this is a public health campaign in 1920, which was there in European countries. Like a simple use of a handkerchief or a hanky while coughing or sneezing can prevent diseases like influenza and tuberculosis. The first medicines like streptomycin and antibiotics came late in the 1916s and 17s. Just by using sanitation, vaccination, and public health measures in Europe in 1950, they were able to reduce the mortality by 90%. That means teaching the community, teaching the students, teaching our patients that you need to use a hanky or the elbow while coughing or sneezing can reduce the spread of tuberculosis and, for that matter, any other communicable diseases. So this was a well-known poster which was used back then, which is of high importance today also. So now we will talk about latent TB and TB disease. What is latent TB and TB disease? From this slide, we can read either when we already said an infected person is throwing out the droplets or aerosols, and then the person is inhaling it. So if the inhaled person can have either of the one, latent TB or a TB disease. If it's a latent TB, then the person doesn't have TB bacteria lives inside the body but doesn't grow, but doesn't multiply. The person doesn't feel sick. The person doesn't spread to another person, and it will not. It may advance to a TB disease in the future. That is latent TB. What is TB disease or tuberculosis? When we say the patient is having tuberculosis, that means the bacteria is multiplying in the body. The person feels sick and have symptoms, and the person is able to spread to many other people, and it can lead to severe disease if not treated, like extrapulmonary TB and miliary TB. So I'm very sure you all know about the signs and symptoms of TB. The common active signs and symptoms of TB are what? Chest pain because of the chronic cough that happens and the bacteria that's causing the infection. Chest pain patients usually complain. Then fever, usually evening fever, mild to moderate fever. Uh, Mild to moderate fever is seen in patients. Persistent cough. If any cough more than 2 to 3 weeks and not getting better is a typical sign and symptom of TB infection, TB symptom, active TB. Then hemoptysis, that is blood in the sputum, fatigue. Even if the person is resting for 24 hours, the person still feels lethargic. Loss of appetite that will lead to weight loss and night sweats are the typical symptoms of active TB infection, TB disease. So when a person have any of these symptoms, maybe one or two, what happens is the person, of course, is going to seek medical help. Even we will go and seek medical help. So it's a then the pattern is crystal clear. The person will be sent for diagnosis whether the person is having tuberculosis, and the treatment will be started according to the drug sensitivity. These days, recently we are using molecular testing like GeneXpert to see whether the person is resistant or sensitive to the drugs that is used in treatment. So the person when comes with the signs and symptoms diagnosed to have TB goes to the TB treatment part. It is crystal clear. So what happens with people who is infected with TB but doesn't have active infection? That is a group of nursing professionals and other healthcare professionals. We fall into the group of LTBI, latent TB infection. That is, what is LTBI? It's a state of persistent immune response to stimulation by Mycobacterium tuberculosis antigens. Whenever the antigens try to increase in number, our immune response stimulates and settles it down. So there is no evidence of clinically manifesting TB disease. There is no gold standard test to identify whether the person is infected or not. We still don't have a no gold standard test, and most people infected have no signs and symptoms of TB, so they don't seek help, and they are at a risk of a TB disease. 5 to 10% they are at a risk of developing TB disease. Next is testing for LTBI. Usually, when we say about testing for LTBI, we have two tests. That is tuberculin skin test, age-old TST that we use, and IGRA, that is immune interferon gamma release assay. So think of a person or a health professional for ourselves. Like most of the private hospitals do have periodic health checkup, which includes blood test as well as chest X-ray. So, and we all know working in ICUs or OPDs or pulmonary wards, we are exposed to tuberculosis infection. So, even if we undergo a chest X-ray, the clinical assessment, the chest X-ray shows that there is suspected TB. There is some consolidation or abnormal chest X-ray. So, the person by the pathway it goes to active TB evaluation. So, there is no confusion there. But if there is the X-ray comes normal, so what can be done? How we will know that we have been infected with TB or not? Then we can go for tuberculin skin test, that is the purified protein derivative PPD, which is injected 0.1 ml intradermally, and the reading is taken 48 to 72 hours later. If the wheel is greater than 10 mm, then the person is said to have latent TB. If it is less than 10 mm, then again the person can undergo interferon gamma release assay. That is an ELISA test. Interferon gamma, it's tested like whole blood is taken and it's exposed to antigens, Mycobacterium tuberculosis antigens, and checked and we check for the response, WBC response to this antigen. So if it comes positive, then again it is latent TB. And if it comes negative, both the tuberculin test and the IGRA comes negative, then it's nothing else to be done. We need to observe that person. So that is the testing that is done for a person to know whether the person has LTBI or not. Next, we have if a person is said to have LTBI, came positive, interferon or the TST came positive, then why we need to tackle this group? As I said, they have 5 to 10% chance of developing into a TB disease in the future. And sometimes what happens is when the symptoms start, like cough, which is being ignored for weeks to months, actually the person in the community is spreading infection to multiple people. So we need to, at this 2024, we need to emphasize on TB preventive treatment, because the TB is prevented at the grassroots level and is not given a chance to advance into a disease stage. So what happens in TB preventive treatment, the steps are, it's identifying individuals at higher risk. Like we health professionals are at the highest risk. So we need to be, we have to undergo the testing for infection. Then excluding for active TB is done. Then choosing the treatment option. Like when we say the treatment for TB is for drug therapy and it has to be taken for 6 months. That was the old protocol. But when we say about TB preventive treatment, the patient or the individual coming has options which I want to choose. Whether I have to go for a 1 month therapy, whether I have to go for 6 months. I can't take so many tablets, so I will take less tablets, but I will take it for 6 months. So there are so many options available now, so that the patient itself can choose what is feasible for them. Then once the treatment option is chose, then managing the adverse effects. Of course, every drug, even if Pandocid comes with some side effects, so every drug has some side effects, and managing the side effects, supporting medication adherence is a major step that we all need to focus on, and monitoring programmatic performance, that whether the TB treatment everybody is covered or not, and the program how it is going. Next is the TB preventive treatment options, which I was telling about. The next slide will tell you in a picturized way. It's a tabular form. Next, please. I hope this is visible. Here we have 3+5 treatment options. Like if I wish to say that I don't want to take 2 tablets, I wish to I only want 1 tablet as a treatment therapy. So isoniazid can be given for a month of 6 months intervals, that should be taken daily. Doses is 182, and 182 tablets is the total treatment option. Or else the patient can opt for a 3-month duration treatment, which has isoniazid and rifampicin. It is not rifampicin, it is rifampicin. It is also a bactericidal drug, which has much lesser adverse effects than rifampicin, and it can be taken along with drugs. One of the problems that patients usually face is taking a tablet khali pet, empty stomach. So when it comes to empty stomach and orange colored urine, for a normal population, it becomes like I had a tablet and my urine is bloody red. So adherence again becomes a problem, and gastric issues also can be decreased with rifampicin. So isoniazid and rifampicin combination, again, it's just 12 doses for a period of 3 months, and it is actually weekly. Then we have another option is isoniazid plus rifampicin. Again, it is a 3-month duration, but it has to be taken for daily, and the doses is 84. Rifampicin alone can be given for a duration of 4 months. That is also daily, and the total doses is 120. Isoniazid plus rifampicin, it's the most commonly and widely accepted, because it's just 1 month duration, that is 28 doses, can gives an assurance that you will be TB free. So according to the patient adherence, what is suiting the patient, or what the medical practitioner as well as the patient is able to choose from this treatment options, TB preventive treatment actually. Okay, so why I emphasized on TB preventive treatment is because I've been into this nursing from 2009. From this maybe this 10-12 years, what I have seen is many of my friends, my colleagues have gone through tuberculosis, infected with tuberculosis, had drug sensitive, drug resistant. So what happens is we usually, it's not a practice that we have in India. We don't check for whether we are infected with TB. We always seek medical help at the advanced stage. So taking a treatment, preventive treatment is much better than treating the disease. I will say why it is better to take a preventive treatment with my journey. So that was an overview of the disease as such, what is tuberculosis, history of it, latent TB disease and infection. Now, what I really want to talk to you this evening is about the psychosocial path a person goes through while taking TB treatment. We all work with patients, people actually with emotions, feelings, day in and day out. So when we come to a government setup, we talk with people very harshly, very rudely. Sometimes we as professionals, as people, we also have our own mood swings, high time, low time. So we don't feel for patient what they feel actually. So having TB thrice, I feel that made me a better person. So before going to what a person goes through, I just want to narrate in short about my TB journey. First, I was diagnosed with TB in 2011. I was working as a nurse in the ICUs at PD Hinduja National Hospital, Mumbai. Then, after a night shift, I had a pain. So my intensivist advised for an X-ray, which had a consolidation. My AFB, sputum culture, and NGIT came negative. But still, I had a patch, so I was radiologically diagnosed with TB, and I was started on 6-month therapy. That 6 months category 1 for drug, isoniazid, rifampicin, ethambutol, and pyrazinamide. That 6 months was very happy. I didn't have much problem. Just some little aches, nausea. I was able to manage work well. Then I came to Delhi for my further education. While I was doing my PG in 2014, again I felt the same pain during an inspiration. Then again the X-ray was done. Then the patch was increased. So then again the same path, for drug plus this time category 2, which included injection streptomycin for 3 months. 90 days getting an IM injection was was a terrible experience. So after 1 month of starting the treatment, it was drug sensitive. So after starting with the treatment, 1 month, I had severe side effects. I had massive pleural effusion. I was stabbed every alternate day. I was admitted in the hospital for 1 month. I was away from my family. My friends, as well as my teachers, really took care of me throughout those periods. Because of my teachers and my friends, I didn't drop the course. It was such a stage that many of the people around me told me, better you should take care of your health, you should drop the course. But people around helped me so much that I was able to complete my master's. Then I joined AIMS as a nursing officer. I was happy. Then because of the pollution and other things, I was going through a rough path of my life. So then I thought I will take a test X-ray to see whether the patch is still there. If it's clear, I'll try for a job abroad. So when I took out the X-ray, it was devastating. The patch was full blown. I had a really bad left lung. It was totally white. So I really didn't know what to do. It was like I was alone again. I didn't know. I'm sorry. Whenever I look back to those days, I can't. I really can't relive those moments. So I didn't know what to do, where to go, whom to talk to. Then I went to again back. The same doctor was taking care of me. So when I went back, they said it is TB relapse for the third time. So when they said TB relapse for the third time, never my AF became positive. The cultures never came positive. So this time I told I want to see one AFB somewhere. So I was advised for bronchoscopy. When I went for bronchoscopy, what happened was it is a very painful procedure. They tried they advanced the tube bronchoscope, both the nostrils, they couldn't get it. So finally they passed the bronchoscope to orally. And the report came like the report cultures showed contaminated with upper respiratory tract flora. So it was like going through all that pain, and the end result was nil. So what to do? Then nothing. Gene expert came resistant to rifampicin, so it was drug resistant. So I knew this time. I knew the path is not going to be easy. I started the treatment from Delhi, but I had syncope, I had vomiting, I totally fatigued. I started losing weight. Then I decided I will go back home. I am a Keralite, so I went back to Kerala to restart my treatment. And to some extent, I did some doctor shopping also. That I was not able to accept the fact I am having a TB relapse for the third time. So when I went back again, the radiologically I was diagnosed to have TB. And so there started the journey. Uh, Days with rifampicin resistant TB. It started from April 2019 to February 2020. Next slide. Days with rifampicin resistant, any drug resistant TB will give the person have a shorter regimen or a longer regimen. So I was started on a shorter regimen, which was about an year time. I had injection kanamycin IMOD for 90 days, 3 months. And when we see into the list, it's just 8 tablets, 8 genre of tablets. But when it added like moxifloxacin 800 mg, it is 2 tablets, 400 mg it comes. So total about 22 tablets I had to take. Plus I had severe vomiting. So MSET was there round the clock. Plus antacids was there. So 24 tablets was there for me to tackle this. So I'll tell you how my day started. It started with I'll get up in the morning, I'll eat something, and then I have to go to the nearest health facility to get the injection, IM injection. So once, and there also it was like students were there, they used to give IM. I really wanted the students to learn, but when it came to like the pain was so much, we always have a dear one. We always feel somebody who causes less pain give the injection. So um, that that part also came into picture. Like my health becomes a priority. You can't experiment on me. So after the injection, when coming back, I was so exhausted that I couldn't even walk. My father used to take me in his arms to the bed. So that hangover will last to about 12 o'clock or 1 o'clock afternoon. Then I'll have my lunch and the rest of the day to have my 22 tablets, not even 24 hours to complete 22 tablets. So it was divided into two or three different parts. And after every meal I used to take, then I used to vomit out. First 3 or 4 months, I don't think none of the tablets went into my stomach. As soon as it reached my stomach, it used to come out. I stayed in day in and out outside my home. There was a courtyard, so um, my mother used to place a mat, and I used to sat, sleep, vomit on the mat. So somehow managed to complete the intensive phase. And when I started with the continuation phase, the injection was over and the tablets was there. Still, the side effects was there. During the continuation phase, one day I felt my vision is blurring. So vision is blurring. Plus, I was little small, minute sounds I was not able to hear. So again, I ran back to the health facility, and ethambutol was put on hold for a period of time, about 1 to 1.5 months. It was put on hold. Then again, it was restarted. So the side effects. Being a health professional, having a master's degree, I've taken case presentations on TB meningitis, but I didn't know the side effects of these drugs. Actually, when we say about the side effects, when we learn, we just for acquiring marks or passing the course, we just learn so many things. But when it comes to self, actually, I didn't know what all side effects these drugs had and how it can be tackled. So that was, in short, my story. So correlating to my what journey I went, and so many other survivors stories that I've heard and I've dealt with, I would like to put forth the next topic, psychosocial issues with MDR TB treatment. So it not only affects psychologically, it has social impact also. A person going through TB treatment. Emotional storm is, I told you, I was already going through a rough path of my life. I already had a poor mental health, which I believe went into or caused as a risk factor to having TB. Plus, having TB again is a risk factor for developing mental health issues. So it is a vicious cycle. If you have poor mental health, you will have TB. If you have TB, you will have poor mental health. So both of this goes hand in hand. And when you as a person, or when you see a person who is striving or struggling with TB, please keep in mind that the person has mental health issues as well. So we need to consider mental health issues from the beginning of someone's TB journey and support them. Depression has been an invisible burden for people with TB. Depression is an invisible burden because already when we when we have a diagnosis that you are having maybe TB or drug resistant TB, then it becomes too much to digest. Hearing the diagnosis itself is a depressive factor. Then psychosocial issues. Next slide, please. Psychological issues, when we speak about, it comes to what a person go through psychologically. Like diagnosis itself is a shock, and the procedures I told you, it can be different blood tests going from center to center. Everything doesn't happen at one place. So you are already sick and you have been asked to roam around different places for different investigations. Then bronchoscopy, it could be, if it's TB meningitis, the person has to go for a lumbar puncture. So different diagnosis as well as going through different procedures, it also puts the person at a psychological trauma. Then treatment phase, the drugs isoniazid, ethambutol, and cycloserine. These drugs cause depression in a patient who is taking TB treatment. So I used to, I'm not crying when I used to travel. Tears used to roll down my eyes. I didn't know why I was crying. There was no reason for me to just sit and cry. I also found so weird that why am I crying? I don't have any reason. My family was also like, why is she crying? I didn't know these drugs are causing me depression, and it just went by. Then pain at IM sites, I told you, daily injections. One day on the left, other side on the right. And every person who goes through, starting with the drugs with severe vomiting, goes through a weight loss. I reduced almost 15 to 20 kgs. So when we don't have the muscle to get an IM injection, it's so painful. Plus, we don't rub the area, so it just becomes like a block. And again, the next day again, it's been in alternative day, it's been again injected at the same site. So the pain at the IM site is so much. I was unable to sleep on my side or sit. I really don't know how I survived those 90 days. And helpless and hopeless. When I left from Delhi to Kerala for my treatment, I was at a state like, okay, I'm not going to survive this time. I'm not going to come back. So I packed everything from Delhi. I packed my bag in such a way that I'm not going to come back to Delhi. And on treatment, there were days I felt I'm going to die. So it was such hopeless feeling a person goes through. Next slide. So I didn't know whom to contact, whom to speak to, how to cope up with the situation. I'm telling you this because when you come across, or when you have, or when and may not be, like God says, none of them should go through the path. But if anybody of you or your known to are going through such a state, there are NGOs working out, there are TB survivor forums where you can reach out for help. You can ask your medical practitioner that you are going through this, I need help. Or you can discuss with your friends. And then comes the point of stigma. TB is such a disease with a lot of stigma and discrimination that happens till date. Because being a health professional, when we see a patient with tuberculosis, the first thing comes to our mind is I don't want to get affected with tuberculosis. I don't want to take this path. Same was with COVID. Like it was totally discriminated. We don't want to touch, we don't want to go in contact with a person who is COVID positive. Same, it's with tuberculosis, even with centuries, it's still there. The family, I have family members who didn't turn up. I had friends, colleagues actually, who didn't want to when I came back after my treatment. During my continuation phase, I came back to Delhi to work again. So there were times my colleagues didn't want to sit with me and have a meal. So the thing I want you to understand is once the TB treatment is started, within 2 weeks the person can't spread TB. The person is not infectious again. So within 2 weeks of adhering to a TB treatment plan, the person will not be able to spread TB. So don't show stigma or discriminate a person who is taking TB treatment. Then TB centers. I had a better interaction with people working in Kerala. But other TB centers, I have really had a bad experience. People, the first time when I entered, these days we don't get TB medicines on a private medical store. We have to go to Dot Center because it's Indian. The scenario is like to tackle what is the number of TB patients in the country. So TB medicines are only provided at Dot Center or at a public-private partnership. That thing is being carried out. So when I first entered the TB center, the thing was wear a mask properly. She was the person who standing in front really shouted at me for not wearing a mask. When I was not coughing, every patient should wear, but still I was not coughing. I didn't had radiologically I was diagnosed, but I was not coughing or sneezing. Maybe that person could have told it in a little more nicer way to wear a mask or offered a mask, better you wear it. So after that incident and many other, I really understand whatever a person feels, the insult or the stigma that a person feels having a contagious disease. Then isolation, going through all these tablets, it's you are already going through a depressive phase with the tablets, whatever you are going through in your life, and the person usually isolates himself from others. So when the isolation happens, what happens is we don't go, people don't go back to TB centers. They leave the treatment and they don't adhere to treatment. So they again, the bacteria doesn't die, so it multiplies and it becomes resistant ones, and it's a little more difficult to tackle. So as well as bullying, one of my friend who is a TB survivor, she was doing her graduate course, and she was always she was so sick. She was admitted multiple times in the hospital, and her friends used to bully her and keep her aside going to the college. So she really did her graduation from home. She dropped the course and she did it from an open distance course. So these are the stigma that's still prevailing in the society. So this year, next slide, WHO came up with this poster. It's time to stand against stigma and discrimination. We should know the disease, we know how to prevent it, how to tackle it, and save ourselves from infection. So stigma and discrimination should be, we should stand against stigma and discrimination. Next is insufficient knowledge. I told you, like being a health professional, I didn't know about the side effects. I didn't know that it's going to it's going to cause depression, but I knew it's going to cause ototoxicity and ocular side effects. So when I had a blurring vision, I went to the I went to seek medical facility. But here I want to narrate the story of Nandita Venkatesh. She actually had TB intestines, for which she underwent surgery in 2007. Next, she had a relapse in 2013, and this time she started with drug MDR TB treatment. And after a 15 minutes nap one afternoon, when she woke up, she couldn't hear what her brother was telling her. It was so shocking for her. Like 15 minutes before, you were able to hear everything, and 15 minutes later, you are totally mute. You can't hear. You can't even hear a single voice. So it was devastating for her. Her video is there in YouTube. She is an internationally renowned speaker, and she works for TV on a global basis. So the thing she pointed out is none of the persons or medical facility health professionals she met warned her about the side effect of such. What what she faced was totally the side effect of a drug. The injection which caused autotoxic drugs, aminoglycoside caused autotoxicity, and that was not warned to her. And something that we give to a patient for curing a disease have caused a irreplaceable damage to a patient. So that's her story. So when you see someone or when you are taking care of a person starting with TB treatment, it's our responsibility also to teach the patients that what the side effects are. For that, we need to know what the side effects are. So, but on a major side effects like ototoxicity, ocular toxicities, GI problems, all mental issues needs to be taught to the patient. Diet, we know diet, like I told you, 1950, 90% of the mortality in Europe was decreased with vaccination, sanitation, and public health measures, like improving the diet. Protein-rich diet is advised in patients having TB treatment. These days, we have Nikshaya Mitra. For those who have not heard about it, Nikshaya Mitra is a government program in which I will be able to support a person for 6 months who is taking TB treatment. I can send money from my account to a person who is taking TB treatment to improve his diet. Like, or we can fund to yeah, organizations, institutions. But at least for one person, if we are able to provide diet, like high protein diet, that would be helping or saving a life of a person. Plus, again, we have 500 rupees government allowance to improve the diet of a person who is taking TB treatment. Those are new things that is coming up, and compliance to drugs. Insufficient knowledge, compliance. Many studies have done across the globe to see why there is poor compliance to drugs. So the major deficient with people not following or adhering to treatment is they don't know that they have to comply for 6 months or 8 months, maybe for 24 months. People always, it's a human tendency. When you feel good, you will have a tendency to drop it. So, sufficient knowledge or educating your patients to comply for this longer regimen at the start of the treatment is necessary. Then coping strategies, as I told you, we have SATB, Survivors Against TB. It's an NGO and various other NGOs like Stop TB Partnership, we are TB. There are so many Facebook, Instagram pages to support TB patients, survivors. Like I've gone through this path, so I know better what another person is going through. Or maybe I didn't know how to take these tablets. Like 22 tablets, I was just vomiting it out. And at one point, I told I don't want to take tablets. I was not able to even drink water. When I'm taking, I was vomiting it out. So I don't know what to do. With such a state, I don't know what to do. I am not able to drink water. The whole GI system is ulcerated. And it hurts. Even if it's a juice, it's hurting when it's going through the GI tract. So that time, my MDR TB coordinator, she said you can take the tablets with inside the banana or inside rice bowls, so that we just swallow it with the food. So that was something that was a new information, and that helped because with the drug we don't taste the drug, and it goes with the food also. So that had much. It actually worked out for me. So there are so many coping strategies. Like when you feel like hopeless, helpless, what to do? Is it okay? Or I'm just feeling so I'm going to die. If there is no way out, what I should do, whom I should speak to. So all these situations, TB survivors or a psychologist is is needed. When we come to MDR TB treatment, a psychologist or a psychiatrist is a part of the treatment. But even I was referred to psychiatrist whenever I had a clinical visit. But what happens is the load is too much, and with a mask we can mask our feelings. When being a TB patient, we always wear a mask. So with mask, we can mask our feelings too. So going to the psychiatrist, everything is okay, everything is fine. Yeah, he will write you for euthymic and nothing else to be done. But inside, what actually we really feel will be conveyed with the person whom we have trust, whom we feel that he is giving time for me, he is there to listen. So coping strategies, not only for TB, for that matter, any disease, any long term or life taking disease needs coping strategies. And being health professionals, we are at maximum time with the patient. We even though we don't take the path, we have seen many stories. Every day we see many patients with different disease conditions, how they cope, how they uh, survive the story. So these stories can be told to your patients who are really striving to struggling and striving to thrive. So next is compliance. This is a verbatim. This is a verbatim from one of my fellow survivors. She said it like in 2018 she was taking her MDR TB regimen days. By the time I deal with the pain from the morning injection, and the set of pills were given, and I was not in my proper senses those times. Throughout the day, throughout the day and night, dealing with side effects from the medicines, no routine and sleepless nights also. It's terrible when the nausea just don't go away. I couldn't even notice all the skin issues at one point, since continuous projectile vomiting didn't give me time to. Even I quoted it because I too had the same verbatim. Because we don't know what time of day it is, whether it is a Monday, Tuesday, what the date. How 3 months or 5 months went by, I don't know. There's no proper census. Coming back, somebody is taking you to the bed. Somehow we are taking medicines. We are just getting puked out. It's just there's no routine. Eating, vomiting, and it's like waiting for death to come. So that was, and I really don't know how to tell you or how a person to comply, how a person can be compliant to such a treatment. So economic burden during treatment, when we say rupees 500 is given by the government for the treatment purpose, expenses that 500 rupees, how a month can be dealt with. For me, it started with every day I had to go to the health facility to get my IM injections. So that itself costs about 100 to 150 per day. Then going to the health facility to see the doctors every week, then every month, then diet. So for a daily wager or a breadwinner of the family, it's very difficult. So the person, when we tell to the person, you have to adhere to the treatment, you have to come for follow up, you have to do these investigations. Expenses are too much that people don't come for follow up. They don't adhere to treatment and they just drop out. Leave policies. I was blessed to have a government job, but then too I had leave problems. Like even though I wrote letters, I wrote applications stating that I am on MDR TB treatment. I'm not able to join the job. I received 3 memos stating I have to come back and join my job on an urgent basis. So TB doesn't come under communicable diseases with a standard paid leave. So that is a problem for those who are working. Even though We do have leave policies for other COVID when we get 7 days leave, but for MDR TB treatment, there is no leave policies that is happening in India, for which many of us are forced to work like breadwinner of the family, have no other choice, have to work even without taking care of their health. Loss of opportunities. Many of the TB survivors have stated that they are college dropouts. They dropped their dream of being UPSC, writing a UPSC exam or many other major exams. Loss of opportunities in job. So, because of the burden of the disease as well as the long treatment regimen, there are so much opportunities that a TB patient loses. Next is living with and after TB. Living with and after TB is living with. Throughout the period, I always had a fear of transmission. Living with my parents, whether taking care of me, whether they will fall sick. So that is a vulnerable group who are at high risk of having TB, and they are the group who has to be treated with TB preventive treatment, TPT. So it's just they are exposed to someone who is having tuberculosis at household, so that they don't have an active disease. So that is the value of TPT. The fear of transmission is always there, and fear of relapse. Till the day I am alive, I will always have the fear of relapse. Whenever I have a cough, today also when I cough or have a chest pain, I first thing comes to my mind is whether I'm having a relapse. Then marriage, many girls, many ladies who are married are thrown out of the family. They are stigmatized, discriminated. Then girls, when we say for proposals like I had TB thrice or I'm a TB survivor, doesn't add well. People are not that open-minded to take up a person who had a past history of TB. And friends, having TB or a contagious disease will help you know who are your real friends are. And having TB really helped me to find out some of my close friends. Then this is the next slide shows this is a qualitative study done across the BRICS, Brazil, China, India, and South Africa, where it shows the determinants, why there is what promotes adherence and what undermines adherence. The people who the participants told that educated and informed on the disease, having access to reliable information sources, having a good family support, and living close to the healthcare, and have family history of TB, and knowing the drug resistance and fear helped them to adhere to the treatment. Whereas people who were less educated on the disease and people who have relied on community advice about TB due to lack of access to info and less support from the family, living further from healthcare, have a higher cost associated with the treatment and suffering with addiction and substance abuse, they had poor adherence to the treatment. So the study also showed that side effects, pill burden, long-term commitment, and restrictions are some of the treatment challenges a person faces. Side effects like vomiting, nausea, insomnia, ophthalmia-related issues, memory loss, brain fog. Patients often feel underprepared for this. When nobody told, all the 3 times I was not told about what I was going to face. First 2 times it was okay, but the third time I felt it would have been better if I was actually prepared for while I was starting with the drugs. Then the pill burden, I told you multiple drugs for a long period of time. It's a really big toll, and restrictions like don't move out, being in an isolated room, and fasting for drugs, and life becomes just frustrating. So why is it important for healthcare workers? Because I already told many times, incorporating essential TB services into routine health interventions uh, needs to be done, because being it a cardio center, neuroscience center, ophthalmology, any department, we come across people who are on TB treatment. So TB treatment as well as people who are having cough, persistent cough, are not treated. So it's our responsibility, being a Indian citizen as well as a health professional, that we need to notify to a medical practitioner that this person is having cough. advice for a X-ray or other TB testing. Then deliver care that is kind, respectful of human rights without stigma. Kind means don't like whatever the person coming with, whatever disease the person may be going through. We need to be kind. We need to respect the human rights of the person and without stigma. Being into this profession, we are at an occupational hazard of developing any disease. For that matter, we can have HIV with a prick, but we can't shout at the patient for having a needle prick. So stigma need to be, we have to take standard precautions, like we wear gloves as a standard precaution. We consider every patient to be infected, blood infected. So wearing a mask should be in practice like a standard precaution. Wearing a mask, it not only saves other person in front of you, as well as it saves you. Being a health professional, why can't we wear a mask than telling somebody else who is coughing or sneezing and protect ourselves. So wearing a mask saves us from the infectious diseases, as well as transmitting diseases also. So mask should be included into a standard precaution thing. So to conclude, that patients with TB have to face many difficulties throughout their treatment period, which often have an adverse effect on their mental health and treatment outcomes. Many TB patients have committed suicide because they have gone through a dark phase of their life. They were not able to cope up. They were hopeless. So, person should be taught about the side effects of the drug and the mental health issues. MDR-TB patients may require multiple supports to help them cope with the difficulties. Not only a psychologist, they may need financial help, they need a treatment help. So multiple support groups or support they need to cope up with the difficulties. Some people actually lost their job, private jobs. I told I was blessed to have a government job, because after 5 months when I came back, I had a job in hand. What if I had a private job? I would have left. I would have been thrown out of my job. So what about daily wages? People who are working on private setups. So some things, some programs has to be undertaken, so that uh, to make sure that these people are going back to work as soon as possible, maybe within a month. Family and peer support are an important key factor associated with successful management of trust in these patients. I humbly request all those who are hearing me to support your peer group, your colleagues, your family, to support your family when they are going through any stress. It need not be tuberculosis itself. Any stress they are going through, they need your support. The proper health education related to the illness and treatment plan should be provided to patients along with family members. When I was crying, my family also was like looking at me. What is happening with me? They were also didn't know why I was vomiting whole day. Why am I losing weight? When I will be okay? So both the family members as well as the patient needs to be educated about the disease, about the treatment plan, and the outcome. There is a need to improve access to the counseling and mental health care. This really has grown through the recent years. There are better counseling, there are better mental health care given to TB patients these days, and we have social networks. So that part is actually being taken care of. So to end with, it's not just curing the TB, but ensuring they go on to live healthy lives beyond. It's just not 6 months or 2 years, 6 months to 2 years that they are okay with. They have many more years to live beyond TB. So being a health professional, being an individual of the community, it's my responsibility to make sure that the individual who is affected have a healthy life. These are my references. I really thank you for the patient hearing.
Thank you, Divya. Thank you, Divya. I may please request all the participants, if you got any queries or any doubts, any questions, any concerns, please feel free to raise in the chat box. We have gone next 10 minutes with us.
So please make use of the chat box to enable Divya to answer your questions and queries if you got any. I think thank you first. Thank you, Divya, for a very elaborate session. I think we had a very beautiful and testimonial section on living with TB, right? Thank you for your elaborate session. And we know that TB is no more a poor man's disease, and there is high incidence of multi-drug resistant tuberculosis among us. And WHO has already initiated that, yes, we can end TB through the various steps that Divya has told us, the innovation, the optimism, etc. And she has very well refreshed our MedSearch, classifying tuberculosis, refreshing our classification of tuberculosis as pulmonary, extrapulmonary, and the miliary TB, which takes 2 years of treatment. And she also showed us a beautiful picture of the public health campaign of 1920, that is use of hanky can prevent many of the communicable disease. So we have also learned about the difference between the latent and active TB diseases, the signs and symptoms. Also, it was new to me regarding the LTBI, that is the latent TB infection. I think most of you, some of you might have already known it. So it was new for me. Thank you, Divya. LTB, the latent TB infection, especially for the healthcare workers, as we are frequently getting, as we know, in our area, we've got TB out there, right? So we are all victims of LTBI. So the various new testing modalities that is raised apart from the tubercular skin test or the classic Montauk's test, the IGRA, the assay. And also she has embarked on the topic of the TB preventive treatment that should be taught, that should be catered to those patient patient caregivers, the parents, the spouse, or the healthcare ones who are actually living with patients of TB, the TB preventive treatment. Thank you, Divya, again for sharing your story. I think most of you, many of us have, even I'm a TB, I've only had once, but I know how Divya might have gone through her journey, that too with when she had experienced her TB the third time, the multi-drug one. So thank you, Divya, for discussing in details the various psychosocial issues with the multi-drug resistant TB treatment, the vicious cycle of tuberculosis, and the mental health. When there is TB, there is increased risk of the incidence of depression and vice versa. So the various psychosocial issues like the psychological trauma, the psychological issues, the stigma that the society or the ostracization that the society offers, the insufficient knowledge about the need for compliance and the coping strategies for the TB patients with TB. Then she has also told about the various NGOs as well as the support from the TB survivors. A good talk with them can motivate us. Okay, a person, many, it will be easy for many to preach, but one who has experience have got a good range of knowledge how they can really empathize with us as she can really fall in our shoes. So the economic burden which the patients with TB will face, the patients, their life with TB, as well as the patient's life after TB, their job, the friends, the marriage, etc. So I think we had a very beautiful session. None of us were bored. We were actually in board with her. Thank you, Divya. Thank you so much. I think anyone have any doubts? Yeah, Mr. Danish Kumar, he is our Tamil Nadu state convener. He has told that, thank you, ma'am, for a thought-provoking session. It was a good learning about the compliance of tuberculosis regimen. Thank you, Danish. And I think she has embarked on the need for taking care of the mental health of the patient along with the physical health. We all know WHO has defined health as the physical, mental, social well-being. So mental health is also should be equally catered when we take care of the physical health of a person. I'm sure that through this webinar, it was an eye-opener to all of us regarding the various new things which we have learned today, the need to empathize with each one who is suffering with us, especially the healthcare workers, to our colleagues, to our human beings, giving a helping hand to them, talking with them, being a good listener, let them speak. the psychology or the psychological status of the person, the psychological issues the person goes through, might be a little talk with them. A talk therapy can create a great cure to the patient. So let's all support our fellow beings suffering with TB or living with TB, and let's strive hard to put an end to TB along with this government and WHO, so that we can make this world a better place to live in. I think we don't have any queries. Thank you, Divya. So we are coming to the end of the webinar. The certificates for the webinar will be uploaded in your respective dashboard in 2 to 3 days. From the NICE websites itself, you can get the certificate for this webinar. So thank you for your patient listening, and thank you. Thank you, Divya.
Thank you, NICE, for giving me this opportunity. And thank you, dear participants, for the patient listening. If anyone wants, please do reach out who are striving or struggling with tuberculosis. Have a good day.
Yeah, thank you.